Foundations of Maternal, Newborn, and Women's Health Nursing by Murray McKinney, Holub, and Jones, 7th edition, Chapter 22, Infant Feeding. Nurses should support and promote breastfeeding as the normal way to feed babies and as the reference against which infant nutrition is considered. Nurses should also partner with other healthcare workers and advocates to ensure that any social, cultural, economic, or educational barriers to breastfeeding are removed. Given the numerous documented health and developmental disadvantages to infants who are not breastfed, breastfeeding support should be viewed as an important health promotion activity and not merely a lifestyle choice. Helping women choose and feel comfortable with a feeding method is an important nursing contribution that requires knowledge of the newborn's nutritional needs and the techniques to meet those needs. Nutritional needs of the newborn. Calories. The full-term newborn needs 85 to 100 calories per kilogram of body weight, 39 to 45 calories per pound, each day if breastfed, and 100 to 110 calories per kilogram, 45 to 50 calories per pound if formula fed. The infant must consume sufficient calories to meet energy needs, prevent the use of body stores, and provide for growth. Breast milk and formulas used for the normal newborn contain 20 calories per ounce. During the early days after birth, infants may lose up to 10% of their birth weight. This loss is a result of normal excretion of extracellular water and meconium, and newborns consuming fewer calories than needed. Newborns have a small stomach capacity and may fall asleep before feeding adequately, or may sleep through feeding times in the early days of life. Nurses and other healthcare providers should consider weight loss in their feeding assessment, but should also consider the quality of a directly observed breastfeeding session, the infant's output, and other clinical factors such as prematurity and jaundice risk. Infants should be evaluated for feeding problems if weight loss exceeds 7% of birth weight, if weight loss continues beyond 3 days of age, or if the birth weight is not regained by 10 days of age in the term infant. This information should be explained to parents. Nutrients. Nutrients needed by the newborn are provided by carbohydrates, proteins, and fats in breast milk or formula. Full-term neonates digest simple carbohydrates and proteins well. Complex carbohydrates and fats are less well digested because of the lack of pancreatic amylase and lipase in a newborn. Vitamins and minerals are provided by both breast milk and formula. Water. The newborn needs larger amounts of fluid in relationship to size than the adult because infants lose water more easily from the skin, kidneys, and intestines. Breast milk or formula supplies the infant's fluid needs. Additional water is unnecessary. Breast milk and formula composition. Breast milk. Breast milk is species-specific, made for human infants, and is the reference point on which to compare necessary infant nutrition. Nutrients in breast milk are proportioned appropriately for the neonate and vary to meet the newborn's changing needs. Breast milk provides protection against infection and is easily digested. Maternal immunoglobulins, leukocytes, antioxidants, enzymes, and hormones important for growth are present in breast milk but are not available in formula. Changes in composition. Composition of breast milk changes in 3 phases: lactogenesis, the production of milk, stages 1, 2, and 3. Lactogenesis 1. Lactogenesis 1 begins during pregnancy and continues during the early days after giving birth. At this time, the breasts secrete colostrum, a thick yellow substance. Colostrum is higher in protein and some vitamins and minerals than mature milk. It is lower in carbohydrates, fat, lactose, and some vitamins. It is rich in immunoglobulins, especially secretory immunoglobulin A, IgA, which helps protect the infant's gastrointestinal GI tract from infection. Colostrum helps establish the normal flora in the intestines, and its laxative effect speeds the passage of meconium. Colostrum is sometimes referred to as liquid gold because of its many benefits. Lactogenesis 2. Lactogenesis 2 begins 2 to 3 days after birth. Transitional milk, milk that gradually changes from colostrum to mature milk, appears over about 10 days. The amount of milk increases rapidly as the milk comes in. Immunoglobulins and proteins decrease, and lactose, fat, and calories increase. The vitamin content is approximately the same as that of mature milk. Lactogenesis 3. Mature milk replaces transitional milk during lactogenesis 3. Because breast milk is bluish and not as thick as colostrum, some mothers think their milk is not rich enough for their infants. Nurses should explain the normal appearance of breast milk to mothers. Mature milk contains approximately 20 calories per ounce and nutrients sufficient to meet the infant's needs. It continues to provide immunoglobulins and other antibacterial components. Discussions of breast milk and its contents refer to mature milk unless otherwise stated. Nutrients. The nutrients provided in breast milk are present in the amounts and proportions needed by the infant. Protein. The concentrations of amino acids in breast milk are suited to the infant's needs and ability to metabolize them. Breast milk is high in taurine, which is important for bile conjugation and brain development. Tyrosine and phenylalanine levels are low in breast milk to correspond to the infant's low levels of enzymes to digest them. Milk proteins produce a lower solute load, the amount of nitrogenous waste and minerals excreted by the kidneys, for the infant's immature kidneys. Casein and whey are the proteins in milk, but their ratio differs significantly in cow's milk and in human milk. Casein forms a large insoluble curd that is harder to digest than the curd from whey, which is very soft. Breast milk is easily digested because it has a high ratio of whey to casein, especially in early lactation. By contrast, formula has a higher ratio of casein to whey, which results in formula-fed babies having firmer stools with a large amount of the protein in formula not digested. Cow's milk is one of the most common allergens. The body's immune system recognizes and may react to the cow's milk protein found in formula. Because breast milk is made for the human infant, it is unlikely to cause allergies. However, antigens in foods the mother has eaten may pass into her milk. If the infant reacts to the mother's diet, the offending food should be identified and eliminated. Foods in the mother's diet that are most likely to trigger an allergic response in an infant are those from dairy sources, shellfish, peanuts, and tree nuts. Studies have been unable to determine whether infants whose mothers avoid eating common allergens are less likely to develop food allergies. Therefore, current recommendations are for mothers to eat a regular, unrestricted diet during pregnancy and while breastfeeding. Only after a food allergy is suspected in a breastfeeding infant might a mother be encouraged to modify her diet. Carbohydrate. Lactose is the major carbohydrate in breast milk. It improves absorption of calcium and provides energy for brain growth. Other carbohydrates in breast milk increase intestinal acidity and impede growth of pathogens. Fat. Fat provides 50% of the calories in breast milk. The fat in breast milk is more easily digested by the newborn than that in cow's milk. The amount of fat in breast milk varies during the feeding, between feedings, and on the same or different days. Hind milk, the milk produced at the end of the feeding, is higher in fat than fore milk, the milk produced at the beginning of the feeding. Hind milk produces satiety and helps the infant gain weight. Triglycerides form the majority of fat content. Cholesterol and essential fatty acids, such as the long-chain polyunsaturated fatty acids, docosahexaenoic acid, and arachidonic acid, are also present. These nutrients are important for vision and for the growth of the brain and the nervous system. Vitamins. Levels of vitamin A, E, and C are high in breast milk. The vitamin D content of breast milk is low, and daily supplementation with 400 international units is recommended within the first few days of life. Breastfeeding infants who are not exposed to the sun and those with dark skin are particularly at risk for insufficient vitamin D. Infants receiving adequate amounts of formula do not need added vitamin D because it is present in formula. The presence of water-soluble vitamins in breast milk varies according to the mother's intake. The infant of a vegan mother may need supplementation with vitamin B12. Minerals. The casein protein in cow's milk interferes with iron absorption. Although the level of iron in breast milk is lower than that in formula, it is absorbed 5 times as well, and breastfed infants are rarely deficient in iron. The full-term infant who is breastfed exclusively maintains iron stores for the first 6 months of life. Generally, iron is added when the infant begins eating solids. Preterm infants need iron supplements earlier. All formula-fed infants should receive iron-fortified formula. Sodium, calcium, and phosphorus levels are higher in cow's milk than in human milk. This difference could cause an excessively high renal solute load if formula is not diluted properly. Fluoride supplements may be given starting at 6 months of age to improve dental health, depending on fluoridation of water in the area. Enzymes. Breast milk contains enzymes that aid in digestion. The amount of pancreatic amylase necessary for digestion of carbohydrates is low in the newborn, but present in breast milk. Breast milk also contains lipase to increase fat digestion. Infection-preventing components. Other factors present in human milk help prevent infection in the newborn. Bifidus factor promotes the growth of Lactobacillus bifidus, an important part of the intestinal flora that helps produce an acidic environment in the GI tract. This protects the infant against infection from common intestinal pathogens. Leukocytes, present in breast milk, also help protect against infection. Macrophages are the most abundant and secrete lysosome and lactoferrin. Lysosome is a bacteriolytic enzyme that acts against gram-positive and enteric bacteria. Lactoferrin is a protein that binds iron in iron-dependent bacteria, preventing their growth. It also makes the iron in milk absorbed more easily. Giving infants supplementary iron may interfere with the effectiveness of lactoferrin. Immunoglobulins are present in highest amounts in colostrum, but also are present throughout lactation. Higher levels occur when the infant is born prematurely. Lymphocytes in the milk produce secretory IgA, which helps prevent viral or bacterial invasion of the intestinal mucosa, resulting in fewer intestinal infections. Infants who are not breastfed have an increased incidence of respiratory, GI, and urinary tract infections, otitis media, asthma, diabetes, some cancers, obesity, sudden infant death syndrome, and necrotizing enterocolitis. Effect of maternal diet. Although the fatty acid content of breast milk is influenced by the mother's diet, malnourished mother's milk has about the same proportions of total fat, protein, carbohydrates, and most minerals as milk from those who are well nourished. Levels of water-soluble vitamins in breast milk, however, are affected by the mother's intake and stores. It is important for breastfeeding women to eat a well-balanced diet to maintain their own health and energy levels. Formulas. Commercial formulas are produced to replace or supplement breast milk. They are sometimes called breast milk substitutes or artificial breast milk because manufacturers must adapt them to correspond to the components in breast milk as much as possible. However, an exact match is impossible, and although formula provides adequate nutrition, it cannot provide the important immunologic components of breast milk. A variety of formulas, which differ in price and ingredients, are available. Cow's milk. Unmodified cow's milk, whole milk, low-fat milk, or fat-free milk is not recommended for infants under 12 months of age. It contains too much protein and sodium and lacks essential fatty acids, vitamin C, iron, zinc, and other nutrients. Modified cow's milk is the source of most commercial formulas. Manufacturers specifically formulate it for infants by reducing protein content to decrease renal solute load. Saturated fat is removed and replaced with vegetable fats. Vitamins and other nutrients are added to stimulate the contents of breast milk. Formula with added iron should be used for all infants receiving formula. Formulas for infants with special needs. Soy formula may be given to infants with galactosemia or lactase deficiency, and to those whose families are vegetarians. Soy milk is derived from the protein of soybeans and supplemented with amino acids. Protein hydrolysate formulas are better tolerated by infants with allergies. The protein is treated to make it less allergenic. The formulas are also used for infants with malabsorption disorders. Amino acid formulas are used for allergic infants who do not thrive on hydrolyzed protein formulas. The preterm infant may require a more concentrated formula with more calories in less liquid. Modifications of other nutrients are also made. Human milk fortifiers can be added to breast milk to adapt it for preterm infants. Lactose-free formula uses primarily glucose instead of lactose for infants who do not tolerate lactose. Low phenylalanine formulas are needed for infants with phenylketonuria, PKU, a deficiency in the enzyme to digest phenylalanine found in standard formulas. Considerations in choosing a feeding method. Nurses should encourage breastfeeding as the best method of feeding most infants. Unless there is a rare circumstance that contraindicates breastfeeding, nurses should provide patient and family education on the risks of formula feeding as well as on the benefits of breastfeeding. This patient education should begin early in pregnancy. However, nurses should be supportive of the mother's chosen method once a fully informed decision has been made. Breastfeeding. Mothers choose breastfeeding because, in almost all cases, it is the best choice for the health of the mother and infant. Box 22.2 presents the risks of not breastfeeding. Box 22.2, Risks of Not Breastfeeding. For the infant, allergies are more likely to develop. Not receiving the immunologic properties of breast milk increases the risk for infections. Increased incidence of necrotizing enterocolitis and respiratory tract, ear, urinary tract, and gastrointestinal tract infections. Increased incidence of diabetes, asthma, obesity, some cancers, sudden infant death syndrome. Formula's nutritional and immunologic properties do not change according to the infant's needs. Formula is not as easily digested and nutrients are not as well absorbed. Protein, fat, and carbohydrate do not occur in the most suitable proportions in formula. Formula can be improperly and potentially dangerously diluted. Formula can be contaminated and can be affected by water supply. Formula is more easily overfed. Constipation is more common. For the mother, formula feeding does not release oxytocin. Oxytocin enhances uterine involution. Mother loses more blood because of earlier return of menses. Mother resumes ovulation earlier. Increased incidence of some cancers. Mother receives less rest while feeding. A balanced maternal diet that improves healing is less likely. Less frequent skin to skin contact can be detrimental to bonding. Inconvenient. Bottles to wash and formula to buy, prepare, or heat. Expensive. Cost of formula and bottles and time spent in preparation. Infant is more likely to be ill, increasing medical care costs. Working mothers miss more days of work to care for sick infants. Travel more difficult. Bottles to prepare, carry, refrigerate, and warm. It has been increasingly recognized that formula feeding can never fully equal breastfeeding in terms of providing for the infant's optimal health, growth, and development. The American Academy of Pediatrics recommends that infants receive only breast milk for the first 6 months after birth. Breastfeeding should continue until the infant is at least 12 months old, with the addition of complementary foods. Breastfeeding and support to help mothers achieve it are also recommended by the World Health Organization and the U.S. Surgeon General. A goal set by the DHHS for the year 2020 is for 81.9% of all infants to be breastfed at some time, for at least 60.5% to be breastfeeding at 6 months, and 34.1% at 1 year of life. Additional goals are to increase the number of mothers who exclusively breastfeed their infants through 3 months to 44.3%, and through 6 months to 23.7%. One study found that if 90% of women breastfeed exclusively for 6 months, the United States would prevent 721 infant deaths annually, mostly the result of SIDS and necrotizing enterocolitis, and 2,619 deaths of women, mostly due to increased lifetime risks for heart attacks, breast cancer, and diabetes in women who do not optimally breastfeed. In addition, the United States would save $3 billion per year in healthcare costs. The Centers for Disease Control and Prevention reports that in 2013, 81.1% of infants were ever breastfed. At 6 months, 51.8% of mothers were breastfeeding, and at 12 months, the rate was 30.7% breastfeeding. These statistics show a gradual but steady increase over previous years, but continued improvement is needed. In an effort to promote breastfeeding, the United Nations Children's Fund, the WHO, and the U.S. Surgeon General advocate that birth facilities become designated through the Baby-Friendly Hospital Initiative. Guidelines to becoming certified as a baby-friendly hospital emphasize education of staff and parents about breastfeeding, early initiation of breastfeeding, demand feedings, rooming in, no pacifiers, and avoidance of formula unless medically indicated. In 2016, 17.9% of U.S. hospitals were certified as baby-friendly. The Joint Commission 2011 has issued a brochure titled Speak Up for women who want to breastfeed. They encourage mothers to ask for help with breastfeeding. Skin-to-skin contact, breastfeeding as soon as possible after birth, and avoidance of formula or water, unless medically indicated, are emphasized. The brochure is available at www.blablabla.com. Formula feeding. Parents choose formula feeding for many reasons. Some women are embarrassed by breastfeeding, seeing their breasts only in a sexual context. Many mothers have few relatives or friends who have had breastfeeding experiences. A woman may feel a need to maintain a strict feeding schedule and be uneasy not knowing exactly how much milk the infant consumes at each feeding. Her partner or mother may not be supportive of breastfeeding. Rarely, a woman must take medications that might harm the infant. A frequent reason mothers choose formula feeding instead of breastfeeding is lack of understanding and education about the two methods. Combination feeding. Some parents prefer a combination of breastfeeding and formula feeding. Unless medically indicated, it is best to delay giving bottles or formulas until lactation has been well established when the infant is 3 to 4 weeks of age. Giving formula to breastfeeding infants leads to a decrease in breastfeeding frequency and milk production. making successful breastfeeding less likely. Nurses can inform mothers who wish to combination feed of the option of expressing breast milk so that the baby can bottle feed breast milk instead of formula. If the mother chooses to both breastfeed and formula feed after being fully educated, however, the nurse should be supportive so that the mother and infant receive the benefits of breastfeeding at least part of the time. Factors influencing choice. Many factors influence a woman's choice of feeding method. These factors must be considered when educating women about their choices because breastfeeding education is an important health promotion activity and is not just a lifestyle choice. Support from others. Family members and friends may share in the decision-making process. Women with a support system are more likely to begin breastfeeding and continue longer than those without a perceived support system. The woman's partner and the baby's grandmothers are often important influences in determining whether women breastfeed. Advice from friends who have breastfed may also influence the woman's decision. The woman with little support or active discouragement from her family is more likely to have a difficult time breastfeeding. Some women choose not to breastfeed because of their partner's objections. Involvement of the father in infant care is important in some families, and some may think it is possible mainly with feedings. Nurses can suggest other ways fathers can participate in infant care, for example, holding, rocking, and bathing infants. Educating family members about the importance of breastfeeding and risks of formula feeding may lead to their encouragement and support as well. Prenatal classes that include breastfeeding information may help a woman decide to breastfeed and may help her develop confidence that she will be successful. Support people, such as fathers and grandmothers, also should attend the classes so they can learn techniques to help cope with any challenges that might arise. Prenatal breastfeeding classes, individual and group breastfeeding support groups, and breastfeeding counseling are all associated with increased breastfeeding initiation and duration. Encouragement from the woman's healthcare provider may be a powerful influence in the woman choosing to breastfeed. The support the mother receives from the nursing staff plays a significant part in whether she feels comfortable with her choice of feeding method. The mother who does not feel confident in her ability to breastfeed before she leaves the birth facility is less likely to continue breastfeeding if she encounters difficulties at home. Culture. Cultural influences may dictate decisions about how a mother feeds her infant. Women who are most likely to breastfeed are Asian, Pacific Islander, or Hispanic. Those with lowest breastfeeding rates include women who are non-Hispanic Black. However, immigrants from countries in which breastfeeding is the norm may breastfeed for shorter durations or not at all because they lack the support system they had in their own country. Hispanic women who are new immigrants are more likely to begin breastfeeding and continue for a longer period than more acculturated immigrants. Some women may think formula feeding is a preferred method in the United States because it is available in birth facilities. They also may think breastfeeding is inferior to formula feeding and consider formula a way to help their infants grow larger and become stronger. Nurses must emphasize the normalcy of breastfeeding and the risks of formula feeding and encourage these women to continue their cultural tradition of breastfeeding. Nurses should be particularly watchful for ways to help mothers from other cultures who wish to breastfeed but fail to do so because of lack of information or support. Nurses should first examine their own cultural attitudes and ideas about breastfeeding. They should then practice culturally competent care by asking families about their cultural practices and beliefs about breastfeeding and helping find ways for the family to both honor their culture and successfully breastfeed. Employment. The need to return to roles outside the home soon after giving birth may cause concern about feeding methods. Unfortunately, returning to work or school is a major cause of discontinuation of breastfeeding. The mother may choose to directly breastfeed while she is not at work and then express her milk for her baby to be fed while she is at work. She may also feed formula from the beginning. Plan a short period of breastfeeding before weaning the infant to formula, or use a combination of breastfeeding and bottle feeding with breast milk or formula. The nurse should encourage women to continue to breastfeed when they return to work and point out the risks of formula feeding. The increased incidence of illness in formula-fed infants means mothers are more likely to miss work to care for the sick infant. This is a disadvantage for the employer as well as the non-breastfeeding family. Nurses who provide practical information about breastfeeding and working, use of breast pumps, and storage of breast milk help a mother continue breastfeeding for a longer period. Pamphlets and books for the working breastfeeding mother are particularly helpful. Referral to a lactation consultant can provide a mother with continued education and support after she goes home. Staff knowledge. It is important that all birth facility staff members have education about how to help women breastfeed and not provide inaccurate or conflicting information to new mothers. Educational programs are effective in helping ensure all staff have the same basic knowledge and skills to help breastfeeding mothers. Programs may involve formal classes, protocols, and self-paced learning modules. Other factors. Other factors also may influence a woman's decision. Her knowledge and past experience with infant feeding are important. Modesty may be an issue for some women who are concerned about breastfeeding in public situations. Maternal education level and parity affect breastfeeding. Higher levels of education and multiparas are more likely to breastfeed and breastfeed longer. Mothers who live in rural areas or the southeastern United States have lower breastfeeding rates compared with women in other parts of the United States. Women who are overweight or underweight are less likely to breastfeed than women who begin their pregnancy at a normal weight. Normal breastfeeding. The anatomy and physiology of the breast are discussed in Chapter 3, and breast changes occurring in pregnancy are discussed in Chapter 6. Breast changes during pregnancy. Breast changes begin early in pregnancy in preparation for the production of milk. The ducts, lobules, and alveoli develop in response to the hormones estrogen, progesterone, human chorionic somatomammotropin, HCS, and prolactin. Prolactin levels are high, but milk production is prevented by estrogen, progesterone, and HCS, which inhibit breast response to prolactin. Colostrum is present by 16 weeks of gestation. Milk production. Milk is produced in the alveoli of the breasts through a complex process by which substances from the mother's bloodstream are reformulated into breast milk. Thus, amino acids, glucose, lipids, enzymes, leukocytes, and other materials are used to manufacture the nutrients needed by the infant. The milk is ejected from the secretory cells of the alveoli into the alveolar lumen by contraction of the myoepithelial cells. From there, it travels through the lactiferous ducts to the nipple. The infant compresses the areola during breastfeeding to move a stream of milk through pores in the nipple. Hormonal changes at birth. Prolactin. At birth, loss of placental hormones results in increasing levels and effectiveness of prolactin and activates milk production. The tactile stimulation of suckling and the removal of colostrum or milk causes continued increased levels of prolactin. Prolactin is secreted at the highest level with suckling and during the night. Levels are high during the early months and then gradually decrease until weaning. Oxytocin. Oxytocin increases in response to nipple stimulation and causes the milk ejection reflex or letdown reflex, the release of milk from the alveoli into the ducts. During feeding, the milk ejection reflex occurs several times. Some mothers have a tingling sensation of the breast when the letdown occurs. When mothers see, hear, or think about their infants, they often have an increase in oxytocin, resulting in letdown of milk, causing milk to drip or spurt from the breasts. Pain or lack of relaxation can inhibit oxytocin release. Oxytocin also causes the uterine contractions mothers may feel at the beginning of breastfeeding sessions. These contractions are beneficial because they hasten involution of the uterus and can decrease postpartum bleeding. Continued milk production. The amount of milk produced depends primarily on adequate stimulation of the breast and removal of the milk by suckling or breast pump, which causes production of prolactin. This supply and demand effect continues throughout lactation. Early and frequent suckling may increase prolactin receptors in the breast and therefore increase the milk-making capacity of the breasts. Therefore, increased demand with more frequent and longer breastfeeding results in more milk being available. If milk or colostrum is not removed from the breasts, components in the milk cause a feedback that decreases prolactin secretion and milk production. The milk in the ducts is absorbed, the alveoli become smaller, the cells return to a resting state, and milk production ends. Preparation of breasts for breastfeeding. Little preparation is needed during pregnancy for breastfeeding. The mother should avoid applying soap on her nipples because it removes the natural protective oils secreted by the Montgomery tubercles of the breasts. The use of creams and nipple rolling, pulling, and rubbing to toughen nipples does not decrease nipple pain after birth and may cause irritation or uterine contractions from release of oxytocin. Breasts should be assessed during pregnancy to identify flat or inverted nipples. Normally, nipples protrude. Flat nipples appear soft like the areola and do not stand erect unless stimulated by rolling them between the fingers. Inverted nipples are retracted into the breast tissue. Both conditions make it more difficult for infants to latch onto the nipples. Some nipples appear normal but draw inward when the areola is compressed in the infant's mouth. Compressing the areola between the thumb and forefinger identifies whether the nipple projects normally or becomes inverted. Nipples that appear inverted early in pregnancy may be improved near the end. The helpfulness of breast shells for flat or inverted nipples is debated. Some find them helpful for some women, and others think they decrease motivation to breastfeed and do not improve nipple eversion. The dome-shaped devices are worn during the last weeks of pregnancy and between feedings after birth. The shells are placed in the bra with the opening over the nipple. They exert slight pressure against the areola to help the nipples protrude. Pumping the breast for a few minutes before feeding helps the nipples protrude and may be more effective. Application of the nursing process. Breastfeeding. Assessment. Assess both the mother and the infant during the breastfeeding process. Various scoring tools have been developed to assess breastfeeding, but none is completely satisfactory. One method often used is the Latch breastfeeding assessment tool. Maternal assessment. Breasts and nipples. Assess the condition of the breasts and nipples and the mother's knowledge about breastfeeding to determine her need for assistance. Examine the breasts and nipples during late pregnancy to identify problems that might interfere with feeding. If this assessment did not occur before birth, examine the breasts and nipples before the initial feeding. Assess the protrusion of the nipples to identify flat or inverted nipples. Ongoing assessments after birth include identification of breast fullness and breast engorgement. Fullness is the swelling of the breasts that may occur early in lactation as a result of increased blood and lymph circulation. It may progress to engorgement if feedings are delayed, too short, or not frequent enough. Palpate the breasts to see if they are soft, filling, or engorged. Soft breasts feel like a cheek. If milk is beginning to fill the breasts or come in, they may be slightly firmer, which is charted as filling. Engorgement is congestion and increased vascularity, edema from obstruction of lymphatic drainage, and Accumulation of milk as lactation is established. Engorged breasts may be hard and tender, with taut, shiny skin. Note any redness, tenderness, and lumps within the breasts. Engorged breasts may not be seen until after discharge from the birth facility. Assess the nipples, which may be red, bruised, blistered, fissured, or bleeding. Ask about nipple tenderness and when it occurs. Evaluate breastfeeding techniques of the mother having problems with her nipples. Knowledge. A mother who is breastfeeding for the first time may have many questions and need substantial guidance during her first attempts. If she has nursed before, she has more knowledge but may have forgotten some aspects and may be unaware of current information that was unavailable when she breastfed her last infant. It is particularly important that all staff give the same instructions to mothers. Conflicting advice is very confusing to mothers trying to learn how to breastfeed. Infant feeding behaviors. Before initiating a breastfeeding session, assess the infant's readiness for feeding. The infant should be awake and hungry. Trying to feed an infant in a deep sleep period is frustrating to both mother and infant. Sucking on the hands, rooting when the cheek or side of the mouth is touched, smacking the lips, and hands and mouth movements are common hunger cues. Feeding should begin before crying, which is a late sign of hunger. Crying infants must be calmed before they are ready to feed. Continue to assess for problems throughout the feeding. Identification of patient problems. Women with and without experience often need information to have a successful breastfeeding experience. A woman's confidence in her ability to breastfeed may be an important determinant of her success. Therefore, nurses should help women increase their confidence and help prevent early weaning. Lack of understanding of breastfeeding techniques and confidence in using them are common patient problems that may lead to breastfeeding problems. Planning. Expected outcomes. Expected outcomes are 1. The infant will breastfeed using nutritive suckling and swallowing for at least 8 feedings per day before discharge. 2. The mother will demonstrate breastfeeding techniques such as positioning and latch as taught before discharge. 3. The mother will verbalize satisfaction and confidence with the breastfeeding process before discharge. Interventions. Interventions are focused on the teaching the nurse should provide all breastfeeding mothers and their support persons. Inexperienced mothers may need detailed teaching. Experienced mothers often need only a review or a clarification about techniques they have used previously. Assisting with the first feeding. Nurses are encouraged to keep babies in uninterrupted skin-to-skin contact with their mothers after birth, and then help mothers begin breastfeeding when they show feeding cues, usually within the first hour after birth. This assumes that both mother and infant are in stable condition. During the first hour after birth, infants are in an alert state and many begin to nurse. Others may nuzzle, lick, or suck intermittently at the breast. Skin-to-skin contact after birth and breastfeeding within the first hour after birth is associated with longer breastfeeding duration. Early breastfeeding provides stimulation for milk production and improves suckling and maternal confidence. Feeding at this time also helps increase early bonding. The mother may be very gratified to see her infant nurse right after birth. Teaching feeding techniques. Position of the mother and infant. Both the mother and the infant must be positioned properly for optimal breastfeeding. Make the mother as comfortable as possible before the feeding begins. Provide pain medications if necessary. Pain or an awkward position may interfere with the letdown reflex and cause her to tire. Provide privacy and prevent interruptions so that she can concentrate on learning techniques. The cradle, football or clutch, and cross cradle holds and the side-lying positions are commonly used. To increase her comfort, use pillows behind the mother's back, over the abdominal incision, if any, and to support her arms. Her shoulders should be relaxed, and she should not be in a hunched position. Arrange folded blankets. or pillows to elevate the infant to the level of the nipple and prevent pulling and tension on the nipple. The infant's head and body should directly face the breast. If the infant must turn the head to reach the breast, swallowing is difficult. The neck should be slightly extended. The infant's body should be aligned so that the ear, shoulder, and hips are in a straight line. Position of the mother's hands. The mother's hand position is also important. She can position her hand in either a C position or a U position, so her hand gently shapes her breast so her fingers and thumb are parallel to the baby's mouth. Her fingers should be behind the areola so the baby has plenty of room to latch onto as much breast tissue as possible. The mother should support her breast in place for the first few weeks if the weight of the breast makes it difficult for the infant to hold onto it. As the infant becomes more adept at breastfeeding, the mother no longer needs to hold the breast. Although mothers worry about the infant's ability to breathe while breastfeeding, indenting the breast tissue near the infant's nostril is unnecessary. This might cause improper positioning of the nipple in the infant's mouth, interfere with the grasp of the nipple, or interfere with milk flow. Bringing the infant's hips closer to the mother and lifting the body to a more horizontal position are usually sufficient if there is concern about the infant's ability to breathe while breastfeeding. Latch-on techniques. Teach the mother techniques to help the infant latch on to the breast. Helping mothers and babies achieve a comfortable latch is a key nursing intervention in the first few days postpartum because correct latch is key to preventing nipple trauma and promoting optimal milk transfer. The infant should be awake and hungry. Undressing a baby and placing him skin to skin with his mother can help a sleepy infant awaken and calm an upset infant. Eliciting latch-on. After positioning the infant to face the breast, instruct the mother to hold her breast so the nipple brushes against the infant's lips. A hungry infant usually opens the mouth, but some need a minute of stroking the area around the mouth. Breast should not be inserted until the infant's mouth is opened widely, or the infant will compress the end of the nipple, causing pain, trauma, and little milk flow. When the infant's mouth is wide, opening with the tongue down and forward over the gum, the mother should latch the baby asymmetrically by aiming her nipple toward the roof of the baby's mouth. She will then quickly bring the infant close to her so that the infant can latch onto the areola with his chin touching the breast first. Suggesting to the mother that during latch-on, the infant opens the mouth as though yawning or eating a large sandwich may help her understand what is needed. Position of the mouth. Assess the position of the infant's mouth on the breast. The infant's lips should be positioned on the areola about 2.5 to 3.8 centimeters, 1 to 1.5 inches, from the base of the nipple to allow the nipple to be drawn toward the back of the mouth. This prevents the infant from sucking on the nipple only, which leads to sore nipples and insufficient milk production. It also places the infant's gums over the ducts, so the milk is released into the mouth as the gums compress the breast. The nurse should note that most of the areola on the underside is covered by the baby's mouth. Some of the areola on the top side may be visible. Assess the position of the infant's tongue by gently pulling down on the lower lip. The tongue should be forward, cupped under the breast and over the top of the lower gums. The lips should be flared outward. Be sure that the lower lip is not turned in, which may result in a friction burn on the lower side of the nipple. Suckling pattern. Teach the mother about the infant's suckling pattern. During nutritive sucking, the infant sucks with smooth, continuous movements with occasional pauses to rest. The infant may swallow after each suck or may suck several times before swallowing. Non-nutritive sucking, in which little or no milk flow is obtained, often occurs when the infant is falling asleep. A fluttery or choppy motion of the jaw, not accompanied by the sound of swallowing, indicates non-nutritive sucking. Explain the milk ejection reflex to the mother. After the mature milk increases in volume, many mothers learn to recognize a feeling of tingling in the nipples as the letdown occurs. The reflex occurs several times throughout the feeding. She will see the infant begin to swallow more rapidly each time a new letdown brings more rapid expulsion of milk. Milk may drip from the opposite breast when the reflex occurs. Mothers often wonder whether their infants are actually receiving milk from the breast. Point out the sound of swallowing when it occurs. A soft ka or ah sound indicates the infant is swallowing colostrum or milk. Short pauses are normal during breastfeeding. Gentle breast massage can help the baby transfer more milk with less effort and keep him awake and involved in the feeding. In addition, gently stroking the baby's back or hands and feet may keep a sleepy baby feeding. Removal from the breast. Teach the mother to remove the infant from the breast if suckling becomes painful. Show her how to avoid trauma to the breast by inserting her finger into the corner of the infant's mouth between the gums to break the suction. She then removes the breast quickly before the infant begins to suck again. Frequency of feedings. Breastfeeding is most successful when babies are not subjected to scheduled feedings, but are instead allowed to feed as frequently and for as long as they show feeding cues. Most babies need to feed 8 to 12 times per day, but these feedings may not be evenly spaced. Frequent feedings are especially important in the early days after birth, while lactation is being established and the infant's stomach capacity is small. Explaining that the hormone prolactin, which is responsible for milk production, is released in increased amounts while the infant is suckling, helps the mother understand the relationship between frequent feeding and milk supply. Long periods between feedings increase the likelihood of breast engorgement. An infant may vary in the length of feedings and time between each feeding. Several feedings close together, sometimes called cluster feedings, are followed by a longer interval between feedings. Cluster feedings may occur on the second or third night at home or in later weeks when an appetite spurt occurs in the infant. An infant's frequent need to nurse may cause the mother to think that her milk supply is inadequate, when in fact it may be normal. Nurses should provide mothers with anticipatory guidance about frequent nighttime feedings and should encourage daytime maternal rest. Length of feedings. Early feedings were once limited to only a few minutes per breast to prevent sore nipples. However, improper positioning rather than time at breast is the usual cause of nipple trauma. When feedings are too short, infants receive little or no colostrum or milk. It may take as long as 5 minutes for the milk ejection, letdown, reflex to occur during the early days after birth. Generally, mothers can allow infants to set the length of feedings. Mothers should be taught to note the quality of a breastfeeding session instead of the length. The infant should suckle vigorously for a certain period, with swallowing noted. Gentle breast massage and infant stimulation can help keep a baby in a nutritive sucking pattern. When choppy, non-nutritive suckling without the sound of swallowing occurs, the mother should burp the infant and complete the feeding at the other breast. When the infant is satisfied, the suckling pattern changes and the infant may fall asleep. Although variations in the length of feedings occur, early feedings that last less than an average of 20 minutes and occur less than 8 times in 24 hours may not be enough. Feeding time increases as needed by the infant over the next few days. Teach the mother that longer feedings do not cause sore nipples if the infant is positioned properly. Explain the differences between foremilk, the watery first milk that quenches the infant's thirst, and hind milk, which comes at the end of the feeding. Hind milk is richer in fat, more satisfying, and leads to weight gain. Feeding for too short a time prevents the infant from getting the hind milk and decreases weight gain. Therefore, the mother should continue feeding on the first side as long as the infant nurses vigorously before burping and continuing on the other breast. Mothers should alternate the breast offered first at each feeding to provide equal stimulation of the breasts.